Good morning, everyone. This is Dr. Seetha Lakshmi, Associate Epidemiologist from Tampa General Hospital and Assistant Professor at University of South Florida. We're going to talk briefly about COVID-19. Of course, the information on this presentation changes so rapidly and daily. It's a moving target. And slides that have a red star marked on the right upper hand corner are subject to change as more information becomes available. So I want to take a minute to acknowledge why we're doing this presentation. I believe it's important to understand the nature of coronavirus, given the fact that we are facing the new SARS coronavirus too. Given the unpredictable course of COVID-19, it's important for healthcare professionals to be familiar with coronaviruses in general and SARS coronavirus 2 specifically, so they can better protect themselves and their communities. Again, as I mentioned previously, it's a moving target. The information is subject to rapid change, and the slides that have an asterisk of red on the right upper hand corner are subject to change as daily information becomes available. So let's talk briefly about what are coronaviruses. Here you're seeing an electron micrograph picture of a coronavirus. Coronaviruses are a group of viruses that have a halo or crown, which is what corona stands for. The crown-like appearance when you view it under electron microscopy. They are a family of RNA viruses that predominantly infect mammals and birds. Currently, there are 7 known strains that are known to infect humans, and most of them circulate in the winter months, causing common cold or upper respiratory tract infections. The 3 strains that we have come to know very well for their fatality of illnesses or severity of illnesses are SARS coronavirus, MERS-CoV, and as things evolve, the SARS coronavirus 2, previously called the novel coronavirus. So the family of Coronaviridae has alpha and beta coronaviruses, which predominantly infect mammals and cause a severe respiratory or GI illness. Now, the clinical range of symptoms might vary, but they have the capability of causing severe illnesses. The gamma and delta coronaviruses infect birds mostly and sometimes can also infect mammals. The next slide you see here shows you kind of the range of infection across species, right? So as you can see in the second column rather here, the natural hosts generally tend to be bats or rodents. And then there is usually an intermediate host, which is often a domesticated animal. And then finally, the species jump that happens into the human host. And here are examples of different coronaviruses that are capable perhaps of doing that. A 5-year longitudinal study revealed the coexistence of highly diverse SARS-related coronaviruses in bat populations in one cave in Yunnan province, China. I think this is an important fact to understand, that these coronaviruses that are present in the bats need to mutate to cause the species jump to happen, and we'll learn a little bit more about it in the next coming up slides. This slide looks very complicated and busy, but it really is not. So the main point I want you to notice here is this S segment of the RNA, right? So here's your 5' end, your 3' end, and here's your S segment. The S segment is important because it codes for the receptor binding domain. Remember, the receptor binding domain gives this RNA virus the ability to bind to its host, whether it's the bat, the domesticated animals, or human beings. This is an important part of the virus's ability to thrive in its host. Since this part of the virus has an ability to mutate, it makes it highly likely to be able to make those mutations, some which might not be helpful, but some which are helpful in acculturating to its host or adapting to its host. So let's talk about briefly about the pathophysiology of the SARS coronavirus 2. So this is a picture of the respiratory epithelium, and you can see the ciliated columnar epithelial cells here. The important part to focus on is that the genome of SARS coronavirus 2 is identical, about 75 to 80% to that of SARS, and binds to the same receptor as of SARS. So that's a human angiotensin converting enzyme receptor. Knowing the genome allows for us to be able to have rapid tests such as reverse transcriptase PCR and targeted antiviral therapies. And this is the part that talks a little bit about the cytopathic effects. The binding of the SARS coronavirus 2 to the ciliated columnar epithelial cells through the human angiotensin converting enzyme receptor right here will lead to a cytopathic effect, and within 96 hours of inoculation you notice that the cilia stopped beating, which is one of the primary innate defense mechanism of the human respiratory epithelium. This is a picture of the wet market in China, and I'm sure a lot of you have heard about the wet markets being the source of the outbreak, and there are a few other theories behind, what are the possibilities are there, but I wanted you to kind of get a visual sense of what a wet market looks like. So as you're aware, the coronaviruses infect birds and the mammals. So you can see there is also bird droppings on this person's shirt here as well. So there is a lot of interaction close interaction between species, and you can see how that could facilitate interspecies jump. There have been a few issues in understanding the novel disease emergence from a pandemic perspective. So in the past 3 years, the United States has closed the Office of Pandemic Response. We've decreased their outreach from 49 to 10 countries, and ended the PREDICT program, which identified 1,000 new viruses and trained more than 5,000 epidemiological responders. The other big issue in us effectively understanding the ongoing epidemic is fake news. You can see multiple examples on this slide where people are talking about possibility of bioweapons and being used intentionally and stuff. So there's a lot of misinformation that is spread out there that makes it hard to communicate the actual severity, the actual methods for prevention. So technology and outbreaks. So I believe there is the good, the bad, and the ugly when it comes to technology and outbreaks. So I want to focus on some of the fake news aspect that we already saw in the previous slides. So this truly is the bad part of technology, when something that looks very authentic, and then it says here, professor warns new coronavirus has the same kill rate as a Spanish flu, which we know is not true. The kill rate for the SARS coronavirus 2 is much lower than that of Spanish flu. So definitely misleading. And this was breaking news: cocaine kills coronavirus. Just people come up with interesting stuff. This is a good part, I believe, for having somebody that can actually take into account an algorithm through artificial intelligence to predict an outbreak faster. And this is very interesting. This is a company called Blue Dot that used an artificial intelligence algorithm, and they identified COVID-19 outbreak about a week ahead of time. It also works with tabulating news, travel, social media, hospital visits, pharma sales to predict disease outbreaks. So that lead time you get in knowing about an epidemic gives you a much faster advantage in containment efforts and prevention efforts. So this would be really interesting as the future evolves to see how artificial intelligent algorithms can help us predict outbreaks faster. Now, this is the updated slide as of yesterday. On the right side, you see the epidemiological curve that is from the Johns Hopkins database. It's a very good database, and it updates very frequently on the number of cases, including worldwide number of cases. On the left here, you can see there is a chronology of events, but the highlight that really I wanted you to focus is how the number of cases have exponentially moved up. And you can see here some of the, at this point where you see this upward trend is where the change in definition of the coronavirus infection happened. So there was clinical definition included with the lab definition, so you can definitely see an uptrend. But when you also break it down by individual number of cases and the percent increase, there is still quite a bit of actual lab confirmed cases in this uptrend as well. It's always helpful to see the shape of the epidemiological curve, right? This is the curve, and it's nice to see it flattening out, but this is too early to predict what is going to happen next, especially with the international cases that are being reported every day. So often SARS coronavirus 2 is compared to influenza. I wanted to give you some juxtaposition of numbers. This is data as of yesterday comparing the flu season this year, the toll it has taken compared to the coronavirus infections, the novel coronavirus infections. So here you see the number of patients with influenza approximated to be about 41 million, number of doctor visits about 19 million, hospitalized patients about 500,000, and deaths so far in the season attributed to influenza alone, 41,000. So this is a team of Chinese researchers that helped decode the SARS coronavirus 2 genome. As you can see, it was such an early phase of the disease. We're not aware of all the modes of transmission at that time. So as you can see, this person is lacking eyewear, and now we know we need to wear eye protection, and we'll go over some of the personal protective equipment in the next slides. So let's talk about transmission. We know a lot of common respiratory viruses, including coronaviruses, are transmitted by droplets. So that's why you'll see droplet precautions on the patients that are being investigated. There is also contact, right? So droplets and contact, that is also known mode of transmission. The next one, I put it here as gastrointestinal. We don't know to what extent this is actually happening. However, if you understand the pathophysiology of coronaviruses, how they affect human beings, there is shedding of coronaviruses in the stool. Whether these particles are infectious, non-infectious, we don't know yet. Asymptomatic persons can transmit infection, and that's not uncommon. We know people with flu can transmit the infection when they're asymptomatic. So this is not unusual. However, it does make it challenging from a containment perspective when asymptomatic persons can transmit infection. Now, there is a question about, can this be transmitted as airborne? Now, airborne, generally you hear about it for tuberculosis, measles, where the infectious particles are much smaller, they remain suspended in air for a much longer period of time. There is amount of controversy surrounding airborne transmission. And you can see this gentleman in the plane is wrapped completely, probably believes in airborne transmission, just like my colleague Dr. Sinnett, and we go back and forth about it. But as of things stand now, there's a lot of unknowns, and all your personal protection and infection control policies will include airborne prevention as well, until we learn more about the virus. So symptoms, usually a dry cough followed by a fever, all your upper respiratory tract symptoms. Most recover, but about 2.5 to 3% can progress into pneumonia, and I'll show you in the next coming up few slides about the case fatality rate. So a few more things about epidemiology for the SARS coronavirus 2 is the number R naught. This number has been used a lot in the media, common articles, newspapers. So essentially what R naught means is that if one person is infected, how many more people will that one person infect? So for example, if an R naught is 1, one person will infect another one person, right? So if an R naught is 2, that one person is going to infect 2 other people. So the R naught for this COVID-19 disease is 2.2. The doubling time is 6.7 days, which basically means that in 6.7 days, if you had 100 infections to start with, you're going to have 200 infections at the end of those 6.7 days. Mean age, around 59 years. Deaths often happen in people with comorbidities, and the ones that are studied, and we'll look over it in the next few slides, is hypertension, cardiovascular diseases, diabetes, underlying immunocompromising conditions, and underlying airway disease. So far, recovery seems to be complete in survivors. Now this is a busy slide. However, I wanted to show you how the age, with the progression of age, you can see the case fatality numbers progress, right? From 0.2 to 14 if you're greater than, close to 15 almost, if you're greater than 80. And that's important to understand, that older adults are much higher rate of death from the SARS coronavirus 2. And look at the occupation aspect of it as well. Yes, there is a male to female preponderance, male case fatality 2.8 and female 1.7. And you can look at the occupation aspect of it, and you can see healthcare workers, the case fatality rate is 0.3 versus other categories. And I think that's important to point out that that perhaps is a reflection of use of personal protective equipment and infection control measures to help decrease nosocomial transmission. Again, this is a study that came out of China CDC over the past week, and the great thing about this study is it has greater than 70,000 cases that were included in the study. So this is the largest study to date we have that kind of gives us a window into the epidemiology of COVID-19. This slide also focuses on the age aspect of it, but I think gives you a very kind of a clean idea in terms of how the number of cases go up. You see between 30 to 79. So you can see that in younger children, not as many cases, which is excellent news, right? The predominantly affected group seems to be 30 to 79 years of age. We'll talk a little bit about healthcare workers, and this has been a major concern given the amount of infectivity of the virus. So to date, we have greater than 1,700 healthcare workers that are infected and 5 dead. And you've seen the picture of this physician who succumbed to the disease and has been on national news. So it's very important for us to understand the basic infection prevention aspects and how we can protect ourselves and our communities from COVID-19. It's important to follow meticulous personal protection. Make sure you wear your gowns, gloves, mask, and eye protection. Make sure you're donning and doffing properly. And this is very important and part of something that all frontline healthcare providers should understand and know. So, just a lighter moment. You know what goes great with coronavirus? Lyme disease, right? Well, jokes aside, what does go well with COVID-19, the season right now, is that of other respiratory viruses, including influenza. So how can you protect yourself, right? So definitely make sure you have gotten flu shot. There are a few other non-pharmaceutical interventions that are out there. We looked at the evidence. Always hand washing, right? Hand washing with soap and water, hand washing with alcohol-based hand sanitizer. It's very important that you practice hand washing. And face masks, there have been a lot of questions around face masks, use of face masks. If used properly, yes, they can be protective. In a healthcare setting, you have to use a face mask. It's an N95 face mask. Make sure you're properly fit tested. So it's absolutely important. And then surface cleaning. The range of survival of the SARS coronavirus 2 lasts anywhere between 7 to 9 days on the surfaces, depending on what type of surfaces, exposure to sunlight, many other factors. So surface cleaning is also part of the protection plan. This is a picture of a co-pilot that was on the plane that was part of the mission to evacuate diplomats from Hubei province. And as you can see, he's definitely wearing his personal protective equipment. It was early on in the epidemic. There were a lot of unknowns, but definitely taking proper precautions. This is a picture of people standing in line in China, trying to get the masks. So this is part of the surge capacity planning, right? So if you have an epidemic, how it affects supply, demand, and the changes that come with it. So the future is unpredictable. We expect more person-to-person spread. Pandemic, basically pandemic is an epidemic on 2 or more continents versus it being contained. As of things stand today, there are many more cases reported out of Italy, South Korea, so we have to stay tuned and see how this pans out. But definitely it's concerning the amount of spread that has happened over a short period of time, and despite a lot of aggressive measures such as quarantining entire provinces. So expect some more cases in the US and Florida. We definitely urge you to follow reliable source of information such as the CDC, Johns Hopkins, and the avian flu diaries, and definitely avoid fake news and the hysteria associated with it. Again, we want to emphasize, protect yourself, wear the gown, gloves, mask, and eye protection, and make sure you feel comfortable donning and doffing your personal protective equipment as you provide care for these patients. So what institutions should consider in case of an epidemic? There are various thoughts and measures that have variable degree of successes, right? Workplace containment. So recommended, of course, if you're sick, have a fever and a cough, please seek medical attention. Don't go to work. If you're exposed, quarantine yourself for 14 days. And then workplace measures that decreases the amount of crowding of people in one place, teleworking. I think Hong Kong has implemented a lot of these, staggering shifts, loosening sick leave policy, decreasing travel. And then school measures which are variably effective are excluding sick students, decreasing class mixing, closure during an epidemic, and definitely improving hand hygiene and providing hand sanitizer stations. So it's an interesting perspective, right? Is the glass half full or half empty? It's important to recognize that most of the illnesses, including the study that came out of China CDC, show that majority of the illnesses are mild and most patients fully recover. It's definitely great news that children have a lower risk of severe illnesses, and the virus does not appear to pass from mother to fetus or cause any birth defects. So this is a great quote from Sir William Osler, "Medicine is a science of uncertainty and an art of probability." These are very uncertain times. There's a lot of uncertainty about what's going to happen next, how much spread is going to happen. Are we at the edge of a pandemic? However, it's probable that we have to be very prepared, and we will likely see more cases. And stay tuned to see how things progress. Thank you.